Well, good morning and welcome to the 2020 Parkinson Foundation of the National Capital Area Symposium. I hope you're all being safe during these unusual times we're going to. So my topic today is to discuss how were the medicines that we use to treat the motor symptoms of Parkinson's disease discovered, and I'm going to try to explain how do these medications work. So the story actually goes back to the 1950s. Scientists were trying to discover how do nerve cells communicate with each other. We know that nerve cells transmit electrical impulses from one cell to the other, but how do the nerve cells talk to each other? And it turns out that the communication is by the release of chemicals at the end of one nerve. These chemicals are called neurotransmitters, and the neurotransmitters are like a lock and a key. Certain nerves respond to specific types of neurotransmitters. And just like every key doesn't open every lock, every neurotransmitter doesn't stimulate every nerve. And they realized that there were several important neurotransmitters. So back in the 1950s, the important neurotransmitters were thought to be serotonin and norepinephrine. These were the known neurotransmitters. There was a chemical called dopamine that was converted into norepinephrine, and dopamine itself was thought to be relatively inconsequential and was nearly needed for the production of the norepinephrine. But then something very interesting happened. Back in the 1950s, a new medicine for treating high blood pressure was developed called reserpine. It was very effective for lowering blood pressure, but it turns out that some patients who received this medicine developed Parkinsonian types of symptoms. They moved more slowly, it affected their mood and their behavior. They just didn't seem to be themselves. And a young scientist working at the National Institutes of Health named Arvid Carlsson did some research to see why was this new medicine causing some of these neurological Parkinsonian-like side effects. So he administered the reserpine to rabbits and found that it made them very sluggish and listless, as you can see in that top little picture that's taken from his article. And he tried to decipher what was it that was making these animals listless. But he realized that replenishing serotonin or noradrenaline didn't seem to help, but that if he replenished dopamine, that the animals seemed to be rejuvenated and frisky, as shown in the bottom picture. Nobody really believed this at first, but Arvid Carlsson clearly demonstrated that dopamine was a neurotransmitter, and it was very important in that it was located in specific local areas of the brain, particularly in an area called the striatum, which in this picture is in the center of the brain, the caudate nucleus and the putamen. Located in the striatum, that was where there were very high focal concentrations of dopamine. Well, how is movement controlled in the brain? Well, you can look at this complicated diagram. That's a contemporary diagram that I'm sure doesn't make much sense to everybody. So let me try to simplify it. A major function of the striatum is to facilitate complex sequences of movement. Well, what does that mean? When you're trying to write, when you're trying to walk, when you're trying to tie your shoes, certain muscles have to contract, certain muscles have to relax, and they have to do so in the right sequence and at the right time. The analogy is like the conductor of a symphony orchestra. The conductor gets everyone playing in unison and in harmony. So if the conductor doesn't show up, the orchestra could still play, but it's not going to be as harmonious and melodious. Likewise, if the striatum isn't coordinating these nerve signals properly, you don't become paralyzed, but you might move a little slower, you might be a little shaky, you might not be very efficient. And they realized this was the part of the brain that wasn't behaving properly in people with Parkinson's disease. Well, the very next year, an Austrian neurologist, Dr. Ole Hornakevich, decided to determine what is dopamine like in the brain of people with neurologic diseases, and he went to the morgue, had brains from patients who had Parkinson's, and using Carlsson's techniques, measured the concentration of dopamine, and he found that people who had had Parkinson's disease during life had severe loss of dopamine in the striatum, but people with other neurologic diseases seem to have normal amounts of dopamine. He speculated that maybe the nerve cells that were being damaged in Parkinson's disease were the nerve cells that normally would produce dopamine, and that perhaps the dopamine had a lot to do with why patients were getting Parkinson's disease. So this was a model of Parkinson's disease that was formulated back in the late 1960s. The nerve cells that normally would produce Parkinson's disease are degenerating. There are fewer dopamine-producing nerve cells. Consequently, there's less dopamine, and consequently, the striatum isn't doing its function the way it should. So if there's a lack of dopamine, one could say, why not just give people oral dopamine? Seems to make sense. It turns out that dopamine has a little electrical charge. It's a neurotransmitter, and chemicals that have electrical charges cannot get from the bloodstream into the brain. The brain has something called the blood-brain barrier that keeps electrically charged chemicals from getting from the bloodstream into the brain, so that orally administered dopamine doesn't increase the amount of dopamine in the brain. And furthermore, if you take dopamine by mouth, or if you have dopamine in the bloodstream, it is extremely, extremely nauseating and very poorly tolerated. But how does the brain manufacture dopamine? So it turns out there are some important enzymes that convert other chemicals into dopamine. And the chemical that's converted to dopamine is an amino acid that's highly prevalent in our diet and also can be synthesized even if you're not getting much in the diet, called tyrosine. Tyrosine is converted by an enzyme to levodopa or L-dopa, and L-dopa is converted to dopamine. That's how the brain normally makes dopamine. There are very few dietary sources of levodopa, but tyrosine is very, very prevalent. And unlike oral dopamine, if you give levodopa by mouth, it can enter the brain. It's what we call a large neutral amino acid. So oral dopamine does get into the brain. And the key observation was made in the late 1960s by Dr. George Coetzee, who found that administering large doses of L-dopa, levodopa, could be very, very effective in reducing the motor symptoms of Parkinson's disease. And this was truly a revolutionary breakthrough, because prior to that time, there was really no effective therapy for treating the symptoms of Parkinson's. Coetzee was not the first person to try levodopa, but he was the most persistent, having patients in the hospital for weeks and weeks and slowly increasing the amount of levodopa they were getting until he saw a therapeutic effect. Well, the reason Coetzee had to give massive amounts of levodopa turns out because most of the levodopa given by mouth is converted by enzymes in the bloodstream to dopamine, which was highly nauseating, and it wasn't well tolerated, and that's why I'm sure none of you are taking just pure levodopa. You're taking carbidopa and levodopa. What does the carbidopa do? Carbidopa blocks the enzyme in the bloodstream that converts levodopa to dopamine, so you don't get a lot of levodopa in the bloodstream where you don't want it. But carbidopa does not cross the blood-brain barrier. It doesn't get into the brain, so that it doesn't prevent levodopa from being converted to dopamine in the brain. So combining carbidopa with levodopa reduces the nausea and other side effects, and it makes it easier for the levodopa to get into the brain. In fact, as an aside, when carbidopa was put on the market, carbidopa-levodopa was put on the market, and it was called Sinemet. That was the brand name, and Sinemet is Latin for sans emesis. Sans is without, emesis is vomiting, because carbidopa-levodopa didn't make patients nauseous, unlike just plain levodopa. Well, all patients who really have Parkinson's disease will notice some improvement with carbidopa-levodopa therapy. Walking better, less stiffness, less discomfort, writing better, improvements in tremor, moving more quickly, and these benefits persist throughout the course of the illness. Some patients find, though, that their tremor might not improve quite as much as the other symptoms. And partly this is because tremor is exacerbated and aggravated by stress, anxiety, excitement, and life is filled with stress and anxiety and excitement. But not only that, there are some other chemical systems in the brain that are affected by Parkinson's disease, and tremor itself is not strictly purely due to lack of dopamine. But I find that a lot of my patients whose tremors are usually under good control tend to focus on that 10% of the time when maybe the tremor isn't well controlled, because tremor is obtrusive, but frankly, generally not a terribly distinct symptom. Well, soon after the introduction of levodopa and carbidopa-levodopa, the pharmaceutical industry decided to do research to see are there other ways of stimulating dopamine receptors. Now remember, dopamine is that little key that goes in the lock of the dopamine receptor, and the pharmaceutical industry developed some artificial keys, medicines that don't really make the brain manufacture more dopamine, but chemicals that will nevertheless tweak and stimulate the dopamine receptors. These are the dopamine receptor agonists, ropinirole, pramipexole, and the rotigotine transdermal patch are the ones currently in use. So these stimulate the dopamine receptors, but the brain isn't actually manufacturing more. So the question comes up, what treatment should be recommended for every person with Parkinson's disease? Exercise. It turns out that long-term outcomes in patients with Parkinson's disease who participate in regular exercise programs and classes have better long-term outcomes with mobility, dexterity, and balance, and also have significant benefits for mental health. But sometimes medication is necessary. How do we decide who needs to have medications for Parkinson's disease? Some patients with very mild symptoms do not necessarily have to be started on medication. But when symptoms interfere with employment or daily activity, or particularly if there's problems with balance, or if the symptoms are embarrassing, then starting medications should not be delayed. And there was a controversy for many years. What is the best initial treatment of Parkinson's disease? Should you go right to carbidopa-levodopa, or should you try one of these dopamine agonists? And there is no rule that's right for every single person, but I think the jury is in that for the vast majority of patients, the ideal initial treatment is probably carbidopa-levodopa. And levodopa is still, now many decades later, the most effective drug treatment for Parkinson's disease. No other medication has proven to be better than carbidopa-levodopa, and it's the gold standard in which we measure other treatments. But if we just briefly compare the benefits and side effects of the carbidopa-levodopa versus the dopamine agonists, we find that in terms of improving motor symptoms, carbidopa-levodopa, if given in the proper dosage, is very robust, whereas the dopamine agonists aren't quite as powerful in alleviating the motor symptoms. But the biggest problem is that the dopamine agonists tend to have more side effects than carbidopa-levodopa. They're more likely to cause nausea. They're more likely to cause orthostatic hypotension. But most significantly, these are the drugs that can stimulate dopamine receptors in behavioral parts of the brain that can trigger impulse control disorders, hallucinations, and psychosis, and also are more likely to cause daytime sleepiness. So on balance, the carbidopa-levodopa for most patients is more efficacious with fewer side effects. Now, many of you, in fact, I'm sure most of you in the audience are taking carbidopa-levodopa, and you notice that there's many different doses available. The first number is the number of milligrams of carbidopa. The second number is the levodopa. And this is a condition where one size doesn't fit all. Every patient is different. The medicine has to be individualized. And I have some patients whose symptoms are well controlled on a little dose of maybe the 25-100, 1/2 tablet 3 times a day. And I've got other patients who may take 1,000 milligrams or more of levodopa. And it has nothing to do with height or weight. There's a big individual variation on what patients need to control their symptoms. But of course, and I'm sure all of you will agree with this, When we talk about how do we manage Parkinson's disease, we certainly want to avoid over-medication. With treating Parkinson's disease, you have to take divided doses, usually 3 or more times a day, and we try to find the dose that controls the target symptoms, and we try to find the lowest dose that does so, because giving more might just lead to more side effects, perhaps without greater benefit. On the same token, we have to avoid under-medication. There is no reason to arbitrarily restrict the dose because everybody is different. Some people need more to control their symptoms, some people need less. And under-medication unnecessarily leads to increased disability. So the doses, the time intervals between doses have to be individualized and titrated. And of course, we need cooperation. You have to work with your doctor. Compliance is important. So the physician has to know what you're taking, and you have to be able to stick with a regimen to see if it works or not before deciding that things need to be changed. Now, there's a lot of misinformation that you might read online, and I can reassure you that levodopa is not toxic and does not stop working, although these are things you might read online. It turns out that over the years, there are some symptoms of Parkinson's disease that are not related to lack of dopamine, and there are some symptoms that are not related to motor impairment, and these are things that generally require other types of treatment besides dopamine-producing medications. So this doesn't mean that the levodopa has stopped working, it just means that other things often have to be added to the treatment. But the important thing to realize is that it doesn't stop working after a certain amount of time. There is no rationale in delaying treatment if the symptoms are bothersome. You cannot save the best response for later. So understanding how dopamine is released in the striatum in the brain helps us better understand the best ways of using this medication. So it turns out that dopamine is a neuromodulator. It isn't tightly linked to specific motions or motor events. The brain relies on a steady, continuous supply of dopamine in order to keep the motor system ready to go into action, to keep the system on guard and ready to act. So normally, in the striatum, we have a fairly steady, continuous level of dopamine. But here's what can happen after a number of years. And this could be after a few years or sometimes after many, many years. But patients are taking their carbidopa, levodopa, and they might find that the symptoms will fluctuate. Sometimes the medicine is working better than others. And these fluctuations can be rather upsetting. Why does this occur? Well, one problem is that when you take levodopa, carbidopa, levodopa together, it has what's called a short half-life. It doesn't stay in the bloodstream that long. So you take a dose on an empty stomach, the levels reach their peak in about 30 minutes or so, but it's out of the system in 2 or 3 hours. It doesn't stick around for a long time. And the brain, as time goes on, has fewer and fewer nerve cells that will manufacture the dopamine, and it's unable, there's no buffer, there's less of a buffer and there's less of a storage capacity, so the symptoms will wax and wane depending on the timing of the medication. Another problem is the fact that levodopa is an amino acid. So if you take it with food with other amino acids, they all compete for absorption into the bloodstream. And in fact, levodopa is not absorbed into the bloodstream from the stomach. The stomach has to empty, and the levodopa is absorbed downstream in the small intestine in an area called the jejunum. So delayed gastric emptying means that some doses will get there quicker and some slower, and some doses will seem like they're acting better than others. But we have all sorts of strategies to ameliorate these fluctuations. The first of which, of course, is that sometimes people have to retime the doses of medication administration. It turns out that higher doses don't last longer. Higher doses might have higher peak blood levels after you take it, but they'll still be out of your system in a couple hours and only have more side effects without longer benefit. So making smaller doses closer together can make a lot of sense and often is all that needs to be done. But there are some carbidopa-levodopa preparations available that have a longer half-life. They stick in the bloodstream a little longer. There's this carbidopa-levodopa CR that has a little bit prolonged half-life compared to regular carbidopa-levodopa. But more recently, we have an extended-release carbidopa-levodopa called Rytari that has little beads. These little beads, a third of them are regular carbidopa-levodopa, but two-thirds have a coating that gives this preparation probably a 4 or 5 hour half-life compared to maybe 2 or 3 hours with regular carbidopa-levodopa. Now, many patients might just find that if they're having a period where the medicine isn't working, they could just pop a little extra dose of oral carbidopa-levodopa. Usually a very small dose can be effective. There's now an inhaled levodopa preparation that you actually gets into the lungs and is into the bloodstream through the lungs by inhalation called Ambrosia. And researchers are trying to develop a patch, a little patch, a carbidopa-levodopa patch for transdermal administration of levodopa to help smooth out these ups and downs. But despite tweaking the carbidopa-levodopa, sometimes we need to add yet another medicine. And I know people shriek when they say, oh my gosh, I need another medicine. And to be honest, I feel the same way. Well, it turns out that the brain has enzymes that break down and metabolize levodopa and break down and metabolize dopamine. And by blocking or inhibiting these enzymes, we can prolong the beneficial effects of the levodopa or prolong the effects of the dopamine. And two of these enzymes, and they have big long names, catechol-O-methyltransferase, or COMT, and monoamine oxidase type B, AOB. So we have medicines on the market that some of you might be taking that block either COMT or MAOB. Entacapone is the most commonly used COMT inhibitor, and MAOB inhibitors, the most commonly used drugs are selegiline, razagiline, and more recently sulfonamide. And these charts are a little confusing, but what they pretend to show is that when you take these medicines, the drug might stick around a little longer in your bloodstream, and you would get a little higher level of the blood of these medicines in the bloodstream. The higher level, of course, might lead to more side effects. Another way of helping patients with fluctuating symptoms is to combine the carbidopa-levodopa with dopamine agonists. These drugs tend to stick around in the bloodstream a little longer, and they tend to help reduce fluctuating symptoms and particularly dyskinesias, which we'll discuss in a moment. But of course, whenever we start using multiple medicines at the same time, we have to watch out for increased risk of side effects. And in particular, with the dopamine agonists combined with carbidopa-levodopa, there's terrible, what we call impulse control disorder. Now, there's a drug that's unfortunately seldom used but very effective called apomorphine. It's an injectable dopamine agonist that works much more potently than the oral dopamine agonists in terms of alleviating symptoms, but it's rather inconvenient and quite expensive, and consequently not used as often as it otherwise might be. But the pharmaceutical industry is rapidly trying to develop an oral form that you can put under your tongue that might be available in the next year or 2 or 3. Well, it turns out dopamine is not the only neurotransmitter affected by the Parkinson's disease. Acetylcholine is another neurotransmitter that's altered, and these are what we call the cholinergic, the acetylcholine pathways. Medicines that block acetylcholine can reduce tremors in patients who don't get a robust response to carbidopa-levodopa. And this is benztropine, trihexyphenidyl. The problem with acetylcholine blockers, or what we call anticholinergic medications, they can cause dry mouth. They can cause constipation. They can make it difficult to urinate, but most significantly, they can cause memory loss and confusion. And consequently, we generally don't use these drugs very often in people with Parkinson's disease. Well, it turns out that parts of the brain that use acetylcholine as a neurotransmitter are also very important in helping cognitive function. And medicines that actually increase or enhance cholinergic transmission, namely rivastigmine or possibly donepezil, can be very useful for patients who are experiencing cognitive slowing, difficulty concentrating, problems with multitasking. So these drugs have a definite role in enhancing cognition by enhancing the cholinergic system. Now, there are other receptors, including adenosine 2A blockers. Turns out adenosine is a neurotransmitter that reduces dopamine release in the brain, and by blocking it with a new medicine called istradefylline might help reduce fluctuations. The glutamine system is also involved in Parkinson's disease, and there's a drug called amantadine can be very effective in reducing dyskinesias and has a definite role for treating many patients with Parkinson's disease. Now, of course, we try to avoid using multiple medicines whenever possible. We try to avoid what's called polypharmacy, but complex medication schedules are sometimes necessary. But once again, we get to the role of the doctor and patient have to work as a team. Compliance is imperative. And for some patients, and this is rather unusual, but some patients we have to use these really complicated medical schedules where patients are taking medicines every few hours and there's multiple medications, and it gets to be quite confusing. And here's where that teamwork is important. Patients should be able to name their medications, the doses they're taking, and the times that they take the dose. Because if someone comes to my office and can't tell me what they're taking and when they're taking it, then my thought is, how could they possibly be taking this correctly at home? These are patients who then would need help from their spouse or care partner, because taking these complicated medication schedules, you have to be reliable and on time. So every patient, all of you, should know your medications, and the names are complicated. At the very least, I would certainly urge every one of you to have a complete list of all of your medications with the doses and the times that you take the medicines, and keep it in your wallet, keep it in your purse, and bring it with you every time you come to see your physician. So what happens when you stimulate the dopaminergic system in Parkinson's disease? The good is you can really help improve the way you're moving and functioning on a day-to-day basis. But we try to avoid the bad and the ugly. We try to avoid significant dyskinesias or fluctuating symptoms, and we certainly try to avoid the ugly, because over-medication or abuse of medication can cause impulse control disorders, psychosis, hallucinations, all sorts of terrible side effects that we try to avoid and can be avoided. And for patients with fluctuations that aren't controlled that well with oral medications, we have these other options that are going to be discussed later in this symposium, namely deep brain stimulation and the continuous infusion of carbidopa-levodopa gel into the genome. But realistically, what is the goal? What is our goal? As a doctor, when we treat the Parkinson patients, what is our goal? It would be wonderful if we could completely eliminate tremor and stiffness and all the symptoms 100% of the time. And sometimes we can, but sometimes we can't. A realistic goal, of course, is to keep all of you functioning in the mainstream of life so you can enjoy your family events, so you can enjoy your hobbies, so you can lead a normal life. This is a realistic goal. Unfortunately, if we aim for perfection, that increases the risk of over-medication and significant side effects. So in conclusion, it's very heartening to know that we do have many effective options for controlling the motor symptoms of Parkinson's disease. Now, as you all know, there are certain and many what we call non-motor symptoms that might affect bowel function, that might affect blood pressure, that might affect mood and anxiety and personality changes. And there are many effective treatment options for these non-motor symptoms as well, so we certainly can't neglect them. It's also good to know that there's a tremendous amount of active research going on that undoubtedly is going to lead to new insights and improved treatments for Parkinson's disease. But as I've mentioned a couple times, the doctor doesn't treat the Parkinson's disease. We make recommendations. You're the ones who have to do the hard work. You've got to follow these medication regimens. And as you know, exercise is so important for improving the long-term outlook in people with Parkinson's disease. And one cannot underestimate the importance of good mental health. And so in many cases, we have to recommend measures to improve mental health and improve sleep and other behavioral aspects of Parkinson's disease. I'm going to conclude by reminding you that optimists and pessimists develop the same illnesses but lead entirely different lives. So once again, we can't underestimate the importance of good mental health. Thank you very much, and I wish you good health in these times of this troubling coronavirus, and best wishes to all of you.